Hi everyone. We might make a start. I think everybody's sort of starting to roll in. I'm Jo Silver. I'm the GP advisor at Western Health, and I'd like to welcome everyone to our education session this evening on diabetic foot disease, a masterclass for the primary care physician. Next slide, please, Chris. I'd like to begin with an acknowledgement of country. We'd like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woiwurrung people, the Boon Wurrung people, and the Wathaurong people. We pay respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. So just a little bit of housekeeping before we get started. Everybody attending is muted. Can you please ask your questions in the Q&A box only, not in the chat box? The session is being recorded and you'll receive a link to the recording and a copy of the slides in post-session email from the PHN and a list of any of the resources that come up. So thank you. Next slide. Please ensure that you have provided the PHN with the name that you've registered with. If you're not sure and you can't change it on your device, then please send Olivia from the PHN who's with us this evening, Eliza, a message in the chat function. So just tell her who you are and your CPD number if you know it. Now, we've got a fantastic team of speakers this evening from our diabetic foot unit. So Charlotte Cook, the senior podiatrist, who's leading the recently expanded diabetes foot unit, Associate Professor Fiona Bodie, endocrinologist and clinical lead of the diabetes foot unit, Dr. Chris Preston, endocrinologist, Mr. Bernard Allard, head of vascular surgery, Dr. Asma Sahal, infectious diseases physician, Dr. Dev Kavat, our deputy head of endocrinology and diabetes, and Dr. Guido, endocrinology advanced trainee. So, and thank you to everybody for all your work presenting this evening. So, and our session, like we said, is diabetic foot disease, a masterclass for the primary care physician. And I'm just going to provide a brief update on some of the information that you'll be able to find on Health Pathways Melbourne as well on diabetic foot disease. So the Health Pathways Melbourne are pathways that are written by GP clinical editors with support from local GPs, hospital-based specialists and other subject matter experts. And the aim is to provide concise information for GPs to guide them in their assessment, management, and then referral into the services in their area, especially if they're unfamiliar with what may be available at the local health service. There are health pathways for diabetes-related foot disease that help you with your initial assessment. So next slide, please. So the assessment slides, and they've got drop-down boxes to for your assessment, looking for any of the red flags like ischemia and neuropathy, and also guide you in what to do if there's any things like ulcers or open wounds with tendons and joints exposed, or any concerns if there's osteomyelitis. So, and then there's the information about how you can do the referrals, links into our Western Health referral guidelines, and there's a suite of relevant pathways for diabetic foot disease. You are able to claim CPD for reading the pathways and going through and looking and updating yourself. So, and you can click onto the CPD tool and record there. Thanks, Chris. Most GPs have got access to health pathways because they have registered. If you haven't registered, so GPs, podiatrists, other allied health nurses are able to apply for an individual login to Health Pathways Melbourne. If you have any difficulties, then please email the Health Pathways Melbourne and they will assist you. Thank you. So I'll hand over to Dev now.
Thanks very much, Joe. Before we move to diabetic foot disease, I just wanted to speak to you for 5 minutes about a novel study for which some of your patients would be eligible. It's a novel treatment for type 2 diabetes, and the study's been conducted at Western Health. Next slide, Chris. What we're doing is an endoscopic treatment for those living with type 2 diabetes, particularly those people who are on 2 oral medications or more who are not on insulin. They can be on a GLP-1 agonist as well. What this procedure does is effectively a gastroscopy where we go a bit further down into the first part of the duodenum and we remove the superficial layer of the duodenum, the mucosa there. And in a number of studies in the world, and there are 3 research groups in the world, this improves diabetes control significantly and is associated with weight loss. Next slide, Chris. What we know is that type 2 diabetes, because of the high fat and high sugar diets that some patients are on, leads to epithelial overgrowth of the duodenum. And this also leads to some problems with insulin resistance and with hormone signaling. So this is just a slide of what unhealthy duodenum taken for someone with type 2 diabetes looks like. You can see a number of features there. So what we do, and we've done 15 patients so far at Western Health in this first in human study, is a gastroscope which is performed by the head of gastroenterology. We go down to the first part of the duodenum. We have a particularly clever modified endoscope which allows direct visualization of where the gastroenterologist is, but also has this catheter, which unfurls a little bit like an umbrella. It makes contact with the inner lining, and in 2 centimeter segments allows us to clean out that slough and clean out that superficial mucosa. There's no radiation involved in the procedure, and there's no guide wire involved in the procedure. It takes about an hour to an hour and a half. After we've done this procedure, 28 days later, we go back in for a scope, and what we see is healthy tissue has basically has grown in its place, and there's effectively a resetting of the hormonal system. The duodenum is known to be the site of GIP, hormone production. You would have heard particularly of GLP, and there are some medications around which you'd be aware of, which are both GIP and GLP. So it might be that by cleaning out all of this area, we induce a more healthy GIP response, and that's associated with the glycemic control improvement. Next slide, Chris. So this is just showing, I guess, what we know about the neuroendocrine system as it sits in the gut and some of these effects. Now, if you were to aggregate all the studies in the world which have been done on this, and it's probably been 300 or 400 patients who've had this procedure all in an experimental setting, they would have an average HbA1c improvement of 1% over a 12-month period, and they would have an average weight loss of about 5% over that same period. Next slide, please. I won't go through this in detail, but it's some of the data which has been published in this space. There is a European group, there's a US-based group, and there's our group. Next slide. What we're looking for is patients who are aged between 22 and 70, with a BMI between now 22 and 45, so it's quite a broad range. HbA1c between 7.1% and 10% on 2 or more non-insulin medications. We do require them to have no history of having gastric surgery or celiac disease, and there are a few other exclusions, including, for example, a heart attack in the last 12 months or a recent diagnosis of cancer, and all of those details are available. If you do refer a patient to us, the procedure and all the follow-up is free. The patients are looked after by Western Health, including the endocrinology team, the diabetes educator, and the dietitian for 12 months around the procedure. The patients, in recognition of their time, get a gift card of $150 after each visit and $500 at the end. They undergo a number of blood tests, DEXA scans for body composition, continuous glucose monitoring. They have the procedure, and then 1 month later, they have the follow-up to ensure everything is healed well. The procedure itself is under a general anesthetic, but the 1 month, and the 6 month reviews are just under sedation. We've done 15 patients so far, and we're looking to recruit another 15 patients for the study. The study is, as you expect, is governed by the TGA and is also governed, in our case, by the US FDA with a high degree of, I guess, surveillance and rigor around it, and is obviously registered with all the required authorities. So if you do have any patients who you think might be interested, even if you're not sure if they fully qualify, please do send their details and your details to us in an email, and this slide deck will go out to you. We'd be very happy to review them and discuss whether they could be part of the trial. Thanks very much.
Thanks, Dev. So welcome everybody to our diabetes foot disease masterclass for the primary care physician. I'm Fiona Bodie. I'm one of the endocrinologists in our diabetes foot unit. We're also joined by Chris Preston, who's another one of our endocrinologists. We've got Charlotte Cook and Eleanor Garnis, who are two of our most senior podiatrists within the service, and Mr. Bernard Allard, who's the head of vascular surgery and acting head of surgery at Western Health, who's been a founding member of our service. We will be joined later by Asma Sahel, who's our infectious diseases physician, so she'll be available to help with any questions you might have going forward. And we're very pleased to introduce Hui Do, who's one of our endocrinology advanced trainees, who'll be presenting some of the research that he's been doing as part of our service. Next slide, please. So we'd also just like to acknowledge the traditional custodians of the lands and waterways on which we all come together and on which we're meeting tonight. And we pay our respects to their elders, past and present. So today we'll start talking about our local burden of diabetes foot-related disease and how it affects us in the West. We'll introduce our service and talk a little bit about some of the developments we've had in our service and what we can offer your patients going forward. Chris will present some case presentations talking about some of our different management techniques, and then we'll talk a little bit about some of the latest guidelines in management from our medical podiatry and then a surgical approach. And then we'll just spend a little bit of time talking about how to refer to us and when, and then we'll hopefully have time for some questions and answers. But we are approachable and we're always happy. If you've got questions, you've got things, please give us a call. We're always keen to chat and engage with the GPs that are referring to our clinic. So with that, I'd like to introduce Hui Do, one of our endocrinology advanced trainees, and he's going to talk a bit about diabetes foot disease and his research on the burden it's having on our patients in the West. Thanks, Hui.
Thanks very much, Fiona, for the introduction. Yes, I thought it'd be quite nice to spend a little bit of time going through our unique demographic here out in the West, and I guess look through the burden of diabetes foot disease, given that our demographic here is quite culturally and socio-economically unique and quite different to other aspects of Victoria, and to know what we're dealing with. So we know, I guess, how common diabetes foot disease is. I'm aware that most of you who have patients who attend and you've managed with diabetes, quite a few of them do present with foot ulcers or foot injuries, in which maybe up to a third of those patients would present with a foot ulcer at least once in their lifetime. Unfortunately, because of how these ulcers develop and with the comorbidities of these patients, that they are unfortunately at a greater risk of death around at the 5-year mark compared to patients who do not develop foot ulcers. Unfortunately, as well, as you can see, the rate of recurrence is quite high, and so once these patients do develop foot ulcers, they unfortunately are at much higher risk. For example, 40 and 65 years of redeveloping ulcers, either at the same site or at different sites, and most of these severe infections may require amputation down the track. Next slide. So in Australia, this data was looking through the Australian consensus data from 2017. And so most recently, this number is actually more close to 1.6 million who are living with diabetes. And as I've mentioned, about a third of them will develop a foot ulcer in their lifetime. A lot of the patients that we see here, the inpatients, about 1/6 of them will have a foot ulcer that needs to be treated whilst they're an inpatient. Quite a few of them are managed with the foot ulcers as their primary presenting complaint, but quite a few others also have them picked up incidentally. And we can see that in the most recent years, there has been an increase of diabetes-related amputations secondary to the increase in prevalence. Next slide. So looking through our data, we thought it'd be very interesting to see in our at least 10-year history with the diabetes foot service here at Western Health, the rates of presentation for diabetes foot disease, the rates of amputations, and the mortality, just to have an idea as to whether or not our service is expanding and growing and meeting the demands of the patients out here in the West. We looked through our electronic medical records over this 10-year period between 2013 and 2022 and identified that more than 37,000 individuals, like unique individuals who presented with diabetes in hospital. This does not include any outpatients, so still quite a large demographic, and we identified that approximately 1/6 of them presented with diabetes foot disease. Next slide. What we saw were quite significant rates in patients with diabetes foot disease, where the majority of them who presented had type 2 diabetes, were male and were Australian born. One of the unique things that we could see on the bottom in terms of the country of birth was how diverse our demographic is, where about 2/3 of patients were born overseas. And with our Charleston Comorbidity Index, quite a few of them were comorbid as well. So a number more than 5 suggests that they're quite significantly comorbid with other issues. In the grey bars on the left, you can see that the number of diabetes presentations has gradually increased throughout the years, the total presentations, and probably due to the scale, the number of diabetes foot disease in the teal appears relatively similar, but on subsequent graphs, we can note that there has been a significant increase in the rates of diabetes foot disease admissions as well. It is quite important for us to manage them as best we can, and if possible, to avoid amputations. As we can see in the graph on the right, any individuals who undergo a minor or more significantly a major amputation, unfortunately, have a longer length of stay in hospital, which runs its own risk as well. With the amputation rate here, you can see the absolute numbers are increasing throughout the years, with the major amputations somewhat being relatively stable. Underneath, we can see that with the linear modelling, that these rates are still relatively significant. And one thought is perhaps that as individuals are living longer, are more living longer with diabetes and with the growing population, and fortunately, the absolute numbers of diabetes foot presentations and amputations will continue to rise. In terms of mortality, we can see that those inpatients who develop diabetes foot disease at the 5-year mortality is doubled compared to those who don't develop foot disease, and this is also includes non-diabetes foot related causes of death. So, for example, cardiac disease, given how comorbid these patients are. Furthermore, at the very bottom, major amputations, their mortality is much significant than those who only undergo minor amputations. So what we found overall was that there was an increased burden of inpatient diabetes and subsequently diabetes foot disease in this 10-year period. And a couple of the factors that, as I mentioned before, include increased life expectancy and duration of diabetes, as well as with the presence of our high-risk foot service, we anticipate further referrals from the health networks. This doesn't necessarily include outpatient data, so we do hope that there are quite a few amputations and interventions that we have prevented, but it's not captured in this data, given that it's only on the inpatient setting. Inpatient prevalence at Western Health, in comparison to other aspects of Victoria and Australia, is slightly higher as well. So we have to be mindful, I guess, that in terms of the volume that comes through here at Western Health. Right. I might hand it back to Fiona.
Thanks so much, Hui. So as you can see, certainly diabetes foot-related disease is a significant problem. It's a problem of the community, and it's something that certainly significantly affects us here in the West. So just want to introduce at this point our service. So next slide, please, Chris. Thank you. So about almost 15 years ago, there was a call to arms, across the country, and we had these kind of articles like this one in MJA, a limb lost every 3 hours, and a real call to arms about how can we reduce diabetic foot disease. And about the same time, we conducted a survey, and it was conducted across Melbourne, where we literally went around as an endocrinology unit and sampled every inpatient to see how many had diabetes, and that was every bit as drawn out as you might imagine. But what you can see is that our burden of diabetes in the West was clearly very significant and higher than any of the other comparable hospitals that were surveyed. And so through that, we drew a lot of data that said we really need this type of service at the West. Next slide. So we know the principles of diabetic foot disease management are really multifactorial. We know that there's really good evidence that wound debridement and pressure offloading is really important, particularly if you've got neuropathic wounds. We know that early institution of appropriate dressings and infection control is also really important. Treatment of that underlying arterial disease and having a pathway to access that treatment in a timely manner, because time is tissue. We know that improved glycemic control and helping with that can not only prevent or help with that wound healing, but also help to prevent other complications from diabetes, because these patients, it's not just the foot wound, it's also all the other comorbidities and all the other complications of their diabetes that they're developing that contribute to that overall increase in their mortality risk. And having a pathway to consider, other aspects of management, like the potential for things like hyperbaric oxygen and the prevention of further ulcers down the track, because we know once you've had one ulcer, you're much more likely to have another ulcer. So we know that the best way to achieve that is through a multidisciplinary service. And with that, we were able to establish the Western Health Diabetes Foot Service. So we have a huge catchment servicing, really much of Melbourne's west. We know it's a socioeconomically and demanding and culturally diverse service, and our initial service was established as an outpatient service, but with inpatient support for patients who were admitted under the endocrinology unit. So podiatry and vascular would help to co-manage those patients and round on them twice a week. But what we've seen is certainly that our referral numbers are going up. Sorry, Chris. And our service has expanded. So we now have a number of dedicated podiatrists who work exclusively within our service. We have 4 endocrinologists in our service. We have our vascular surgical team who work very closely with us, and we're supported by Mr. Allard in our service at all times. We've got our infectious diseases physician who attends asthma, who attends for clinics. We have a dedicated diabetes nurse educator who supports our patients in the service and really helps patients to access the latest technology and make sure that their diabetes management is as optimized as possible. We have an orthopedic surgical service, orthotic technicians, and psychology services as well, because we know that living with a diabetes foot wound has a really significant impact on someone's mental health. They become isolated, they're not able to exercise, they're often not able to work, and having that support is really important to their overall prognosis. And with that, we've also now expanded into the inpatient space. So we now have a diabetes foot unit where we are dedicated to the management of diabetes foot-related disease. So this is for patients where their primary admission problem is a diabetes foot wound. And again, we have access to that same range of multidisciplinary services. We have registrars and consultants who are very experienced in managing diabetes foot-related disease, and they're supported very well by the vascular, infectious diseases, renal, and other specialty teams, as well as our dedicated allied health teams. That service is based at Footscray Hospital. So I guess one of the takeaway messages from tonight, if you're working in the West and you've got patients who need admission for diabetes foot wounds, please ask them to come to Footscray if they can, because that certainly streamlines their care and saves them having to be transferred across campuses. But we're very pleased to be able to keep improving and expanding our service for the people of the West. And I guess as a bit of a brag, we were actually recognised as a centre of excellence earlier this year. So we're one of only 18 diabetes foot services with that recognition across the country. So it certainly recognises the work that we're doing to keep improving things for our patients with diabetes foot disease. So our inpatient service, as I said, is a dedicated inpatient team. We have twice weekly multidisciplinary ward rounds. It is quite a big affair, but it means our patients can really get all of their care needs managed in a one-stop shop, and they certainly have high access to consultant level input into their management. We also have our multidisciplinary outpatient service encompassing all of those teams that I described before, and that runs 5 days a week. We do have emergency appointments available when patients do have new wounds that need to be urgently seen, and we'd encourage you to call our service if it is something urgent, so that we can help facilitate timely care and timely review for those patients. So with that, I'd like to introduce Dr. Chris Preston, who's one of our endocrinologists. He works with our inpatient team as well as from time to time in our outpatient clinic, and he's going to present some case presentations highlighting some of our management techniques. Thank you, Chris.
Thanks, Fiona. So I've got 4 cases actually to go through briefly, but really trying to highlight a bit of the breadth of different presentations of diabetic foot disease. And these are all quite recent patients who've come sort of July and August this year. So the first case is that of a 64-year-old gentleman who came into our emergency department with bilateral blistering wounds to the dorsum of multiple toes. And this was sort of at the end of winter after a burn from sitting too close to the heater. So he didn't actually make contact with it, but because he has lost the sensation in those toes, he didn't realise until it was too late, and he'd developed these blisters. In terms of his past history, he had type 2 diabetes long-standing, diagnosed at age 52, complicated by proliferative diabetic retinopathy, peripheral neuropathy, and peripheral vascular disease, as well as ischemic heart disease complicated by ischemic cardiomyopathy and stage 4 chronic kidney disease. And he was also obese, hypertensive, and hypercholesterolemic. We can see his regular medications listed here, taking note in particular that he was on an SGLT2 inhibitor, obviously for diabetes management, but also for the cardiorenal protective benefits given his history. In terms of his social history, he was living with his wife and son, independent but very well supported, working, and a non-smoker, and really minimal alcohol. And on general examination, he was clearly centrally obese with a body mass index of 32, hypertensive in the emergency department, but overall clinically quite well. So on examination of his feet, firstly, an assessment of his vascular supply. His dorsalis pedis and posterior tibial pulses were preserved bilaterally, as were his toe pressures, so greater than 140 on both sides. But he did have clearly a sort of loss of that protective sensation, so only maintaining sensation to a monofilament in 1 out of 4 sites that we usually check for on the left, but preserved on the right. And I think Charlotte will go through that in a little bit more detail later where we check. And then in terms of what the wounds actually look like, you can see here more significant probably on those toes on the left, multiple toes involved, and then on the right as well. So when we have these patients come through, we want to have a system to try to figure out exactly how significant are these wounds, what is the likelihood that we will need surgical intervention or vascular intervention, and how can we sort of monitor it over time. So the system we use, which is endorsed by the Diabetes Foot Australia, recommendations is called the Wi-Fi classification for wounds. So the breakdown of this is sort of an assessment or grading of the wound itself, any elements of ischemia on examination, and then any elements of local or systemic infection. So for this gentleman, for the wound grading, it's quite shallow wounds. Each of these would get their own Wi-Fi grading, but they were all the same for this gentleman. So 1 for the wound being shallow wounds, a grade of 0 in terms of ischemia, given he has preserved pulses and preserved toe pressures, and there was no local or systemic signs of infection, so it was 0 for that as well. So overall, his Wi-Fi classification was really 1 just for the wound, and the etiology for these wounds for this gentleman was purely neuropathic. According to that Wi-Fi classification of the wounds, the risk of amputation we can convey to him is very low, and also given the pulses and the toe pressures, the benefit of revascularization is very low. So in terms of his management, he underwent a bedside debridement in the cubicle at emergency, had some simple dressings applied, had some wound swabs sent off for microscopy, culture, and sensitivity, and then was provided Darko boots for pressure offloading, which is sort of the mainstay of treatment for this presentation. He's provided education on sort of how to manage those dressings and those Darko boots, and then actually discharged within a number of hours from the emergency department with a plan to come back early to our clinic. So in terms of his progress with those sort of management measures put in place, he did experience significant improvement over about a 3-week course of pressure offloading and dressings, after which he was able to return to his own footwear and return to work and everything, and transition from our outpatient space back to his community podiatry care. And this is the sort of interval change after that 3 weeks, so significant improvement in all of those wounds. So this case is really to highlight the importance of the pathology of the pure neuropathic ulcers, and the importance and improvements that we can see with that pressure offloading and the appropriate dressing care. Moving on to our second case. So this is a case of a 49-year-old woman who presented to our emergency department with a worsening left fifth toe ulcer. This had been present for quite some time, and it had not been responding to a prolonged course of appropriate oral antibiotics in the community. This lady had a history of type 1 diabetes, long-standing, diagnosed at age 23, again complicated by proliferative diabetic retinopathy, peripheral neuropathy, and peripheral vascular disease, and most significantly complicated by end-stage kidney disease, for which she was on hemodialysis. And this itself was also complicated by secondary hyperparathyroidism, for which she had undergone a parathyroidectomy. Her medications are listed here, and in terms of her social history, she was independent, living with friends in a convent, and a non-smoker with no alcohol intake. And on examination, again, centrally obese with a body mass index of 35, but clinically overall quite well, hypoglycemic in ED. So when we assess her foot, again, similar to the first case, she did have preserved vascular supply, so palpable pulses bilaterally at both the dorsalis pedis and posterior tibial pulses. Preserved toe pressures, so 130 and 84 on the left and right respectively. But the main finding really is a complete loss of that protective sensation, so unable to feel the monofilament in any of the 4 sites that we test for on either side. And the appearance of her wound, it doesn't look that significant there. It's quite small, but it is quite deep. And we've got to remember this has been there for quite a number of weeks, not responding to the oral antibiotics. So for her, the concern is how deep does this go? And so her X-ray at the time in emergency did demonstrate that there was already some developed osteomyelitis in that 5th distal phalanx. So that's why we're not really winning with the long-term antibiotics there. So in terms of classifying the wound for this lady, for the wound score, given the depth of the wound, she scores 2 points on that part of the system. But again, there's no sign of ischemia because she has preserved pulses, preserved toe pressures. And then in terms of the infection itself, we do have evidence of that infection going deeper on that X-ray. So she scores a couple of points there as well. So when we put that into her Wi-Fi classification, that comes out with a risk of amputation being moderate and a benefit of revascularization being very low again, given she's got preserved pulses and toe pressures. And similar to that first case, the etiology for this wound is again purely neuropathic. Where it differs, though, is in the management. So this has already progressed to infection, and it's progressed to deep infection involving the bone. And it's not responded to a trial of conservative course in the community. So she elected to undergo a left fifth toe amputation for that curative intent. Our antibiotics after this point are then guided by the bone chips, proximal bone chips that are taken at the end of that operation. And again, she has provided education from our podiatrists and all of our teams, provided Darco boot to give that pressure offloading for the healing. And then really the aim for her is to try to prevent recurrence. And in terms of her progress, she underwent primary wound closure in that toe amputation. Her bone chips did come back with a light growth of skin flora, so that guided her oral antibiotic tail. So she was discharged eventually on day 6 post-operatively on those oral antibiotics, and now she's doing very well with that wound completely healed. This was the wound sort of day 1 post-op. So this one's really sort of highlighting the importance of getting to that source control when infection is involved on top of the initial neuropathic wound. Our next case then is one of a 58-year-old gentleman who came into our department, our emergency department, with painful atraumatic ulcer to the plantar aspect of the right first metatarsal. This is another gentleman with long-standing type 2 diabetes diagnosed at age 40. He's got known peripheral neuropathy and suspected peripheral vascular disease based on symptoms, but not confirmed. And he also has a history of ischemic heart disease with previous bypass. He's hypertensive and hypercholesterolemic. Here are his medications listed, and again to note the utility of the SGLT2 inhibitors in these population. So for that diabetes management, but also the cardiorenal protection. He was a high school teacher. This was actually just at the end of school holidays, so he was looking forward to getting back and going to work when this happened. And he was well supported by his wife and children, a non-smoker and very minimal alcohol. And on examination in emergency, he was clearly in pain, but not systemically unwell. He's actually of quite a slim build, BMI of 24, normotensive and with a normal blood glucose. And so on an assessment of his foot, in contrast to those first 2 cases, you can see the predominant features really are he had no palpable pulses bilaterally for the dorsalis pedis or the posterior tibial pulses. The toe pressure was 60 on the left, but clearly reduced at 18 on the right. He did have some peripheral neuropathy with some loss of protective sensation, but he did have preserved sensation at 3 of the 4 sites we test with the monofilament bilaterally. And then you can appreciate in that photo there that it's a pretty nasty spot to get the ulcer. There's a lot of pressure going through that part of the foot. And there is, quite a bit of surrounding cellulitis. You can see demarcated by that. So for this wound, although the wound itself is shallow, there are clear signs of ischemia being a significant component of this, with the absent pulses and the reduced toe pressure. And then there is signs that the infection sort of locally has spread as well. So he scores a couple of points on the grading system there. So overall, his Wi-Fi classification is listed there. In contrast to the first couple of cases, this is a combined etiology of neuropathic issue as well as ischemia. And his risk of amputation based on that grading is high. So that comes into our conversation with the gentleman really right from the start. And the benefit of revascularization is also high because of the pulses and the pressure. So in terms of his initial management, he went on to have an angiogram and revascularization with a plasty to a stenosis that was identified in the anterior tibial artery. He then went on to have an initial debridement of that ulcer down to healthy tissue. He was on initially broad spectrum antibiotics, and then this was targeted and rationalized based on the bone chips, the growth on the bone chips from that operation. And he was provided a cam boot to provide the pressure offloading required for an ulcer in that location. In terms of his initial progress, as mentioned, we found that occlusion, and that was plastered in that initial angiogram. We did see some initial improvement in the toe pressure, so increased from 18 up to 60. The bone chips returned with a group B streptococcus, so that guided our antibiotic choices going on from there. He had a VAC dressing applied, so that's a negative pressure wound therapy dressing, and then he was discharged via our hospital in the home service. He did experience some initial improvement after leaving hospital. However, unfortunately, the wounds did later deteriorate, and so he was readmitted directly from the hospital and the home team back to our ward. So at this stage, we're wondering, what's going on deeper to this, and concerned that there might be some more extensive infection here. So this is a T1 weighted MRI that was taken at that time. And so on this, we would expect healthy bone to appear white. And you can see some of the sort of midfoot bones are clearly quite healthy, but that metatarsal head is clearly osteomyelitic there, as well as the proximal part of the first phalanx. And there's also some septic arthritis identified there or confirmed there in the first metatarsophalangeal joint space. So quite extensive disease. So because of this, on top of this, he actually had a drop in toe pressure after that initial plasty from the 60 that it improved to back down to 35. So he underwent another angiogram where restenosis of the anterior tibial artery as well as a distal DPA stenosis were identified. At that time, he underwent some further revascularization with 2 further balloon plasties. And he did have to undergo a first toe ray amputation, really to get on top of that source control so that we could really cure this for him. His antibiotics after this point were then guided by the proximal bone chips taken from the most recent operation. And then he had another VAC dressing applied and was discharged again via our hospital and the home team. So this time the bone chips grew a different bacteria, Klebsiella. He did continue to improve clinically with the VAC dressing, and he completed a 6-week course of oral antibiotics guided by that sensitivities of that micro to complete treatment for osteomyelitis. And so that's sort of the wounds just before going from the acute ward back to hospital and the home, and he's now doing very well. So this one sort of highlights that the importance of that source control and really making sure we get the whole extent of disease. And finally, the fourth case is really to highlight sort of some of the different presentations that we see through our service. So this is a case of a 55-year-old gentleman who came into emergency with an atraumatic hot and swollen left foot. He also had long-standing type 2 diabetes diagnosed at age 45, complicated by proliferative diabetic retinopathy and peripheral neuropathy. He was obese, hypertensive, and hypercholesterolemic, and he'd had some complicated previous right ankle fracture. So he had an extensive history with our orthopedic surgical team already. His medications are listed here again with those cardiometabolic renal benefits of the SGLT2 inhibitor and also a GLP-1 for this gentleman. And in terms of his social history, he was well supported, living with his wife, independent, a non-smoker, and a reformed previous heavy alcohol consumer. On examination in emergency, clearly obese at 102 kilograms, but normotensive, hyperglycemic with a blood glucose of 13.8, but overall systemically well. So not looking like someone who's septic. And then on his foot assessment, we can actually see, similar to the first couple of cases, he did have preserved toe pressures bilaterally, preserved DP and PT pulses bilaterally. But the significant finding from this assessment was really that there was complete loss of protective sensation. So no sensation to a monofilament at any of the sites that we test for. And you can see the appearance of his foot there. Although I didn't have a lateral photo to really show the sort of the changes in the midfoot. On top of this, he had a significant temperature difference between this the left foot being 34 degrees and the right foot being 29.4 degrees. So thinking about the Wi-Fi classification, this gentleman doesn't actually have a wound. So this is not something that we use for this gentleman. Instead, he went on and had his sort of baseline assessment foot x-rays. And probably on the right, you can appreciate a bit easier that he has a number of sort of healing subacute fractures. So the second, third, and fifth metatarsal bases, as well as the first proximal phalanx. And there's some bony debris around all of those sites. So this has been going on for a while. And so this is all consistent with Charcot arthropathy. So indeed, this is the diagnosis for this gentleman. It's a diagnosis of acutely active Charcot arthropathy, and this is complicated already by multiple subacute healing fractures in the midfoot. So in terms of the management for this gentleman, he was educated on sort of the pathophysiology of Charcot arthropathy and the role that neuropathy plays in that, consented to a total contact cast. However, did not require any antibiotics because there is no actual bacterial infection involved here, and no indication for surgery either at this stage. In terms of his progress, the mainstay of treatment for this condition is offloading. So he was actually in and out of emergency really quite quickly, in a matter of hours after that initial assessment, and then brought back to our diabetes foot service clinic within a week of that first presentation, and then seen weekly at the start for frequent cast changes and monitoring and assessment of the progress of this Charcot arthropathy, and that's eventually stretched to fortnightly. For this gentleman, it was about 6 months until the arthropathy became inactive. Following this, unfortunately, he did experience a reactivation. However, again, he returned to total contact cast for a period of time, and it responded again to this. And then he's been discharged from our service back to community podiatry. And given his history with the previous complex ankle fractures, he's had close orthopedic consultation throughout this time, but did not require any further surgical procedures on this side. So that was 4 different cases to really highlight sort of some of the different components that contribute to our presentations with diabetic foot disease, and hopefully some of the different management aspects that we use to look at that as well.
Thanks so much, Chris. Yeah, I think it really highlights the individualized approach we take to managing our patients. And I guess we'll move into talking about some of that management now. Just happy to, next slide, please. So I guess when we think about the management of diabetes foot disease, there's a number of different aspects. So obviously, we've got the management of the wound, management of the blood supply, management of the dressings and the offloading, but also we're thinking about management of the diabetes. And this is often a really opportune time for us to try and intervene and try to optimize someone's diabetes and link them in with our services, and help them. They're often really motivated at this point in time to actually get on top of their blood glucose levels and really engage with diabetes management. So you'd all be very familiar with our annual cycles of care. Your HbA1c of around 7%, although we do optimize. That is individualized depending on our patients. So obviously, if someone's very elderly or with a lot of comorbidities, we might prefer to see their blood glucose levels a little bit higher, recognizing that hypoglycemia is very dangerous for those patients. Equally, if we've got a very young patient who can achieve a slightly lower HbA1c without any hypoglycemia, then that might help to set them up for less complications down the track. But as part of that, and one of the things I guess that people often forget is that foot assessment, and asking patients when you see them when they've got diabetes, how are your feet going? Having a look at them, and certainly for those higher risk patients, asking them to go and see their podiatrist regularly. Once people have a diabetes foot wound, as I said, this is a really it's a multidisciplinary approach to the management of that wound. So certainly we look at the patient, we try to address their medical and diabetes history, optimize their lipids, optimize their blood pressure control, look at all their other cardiovascular risk factors. But then with respect to the wound, we really need to think about, is this a neuropathic wound, is it an arterial wound, an ischemic wound, or is it both? So certainly with any form of neuropathy, offloading and keeping the pressure off that wound is going to be critical to helping that wound to heal. And Charlotte Cook, one of our senior podiatrists, will talk more about different strategies we have to achieve that. Certainly where there's signs of peripheral vascular disease and ischemia, then optimizing blood flow is going to be really important. And Bernard Allard will speak more about approaches we have there, but really, I guess, assessing for ischemia and trying to facilitate timely access to revascularization is a key part of helping these wounds to heal. Infection, I'll talk more about now, but certainly looking for signs of infection. Not every diabetes foot wound is infected, and so not every wound does need antibiotic cover. But the antibiotic choices that we make really are a little bit different in a diabetes foot related a diabetes-related foot wound, as opposed to other wounds, and certainly our duration of antibiotics can vary. So when we look at the therapeutic guidelines, as you'll notice, these are really driven to encompass a more broad spectrum antibiotic to start, and then subsequently looking at de-escalating once you've got the results of wound cultures. So if a wound is not infected, we don't necessarily need a wound culture. Every wound will probably grow something. But where that infection is present, then obviously the wound culture can help direct the antibiotic cover. But certainly in patients with diabetes foot-related wounds, we tend to try a broad spectrum antibiotic. So traditionally, we'd use Augmentin Duo Fort or Augmentin Duo, where we need to dose reduce for renal failure. We do, I guess, where there's penicillin allergies, if someone has tolerated cephalosporins in the past, then Keflex is appropriate. Because one of the things to be aware of is that cefazolin, if someone has a penicillin allergy, where they've tolerated cefazolin, the side chain can be a bit different to Keflex. So just because you've tolerated cefazolin doesn't necessarily mean you tolerate Keflex if you have a penicillin allergy. But certainly where possible, we try to look at a broad spectrum of antibiotic cover to start. Where we know that someone has a risk of MRSA, we might, or has grown MRSA from that wound before, we might preference MRSA cover. So with something like Bactrim, but you do have to be very careful, particularly people with diabetes and kidney disease are at risk of a hyperkalemia with Bactrim. So you do need to monitor their renal function and their potassium when we start Bactrim therapy. Sorry, Chris. So in terms of antibiotic duration, I think this is probably one of the things that does cause a bit of controversy, and one of the things that we really hope to partner with our referring GPs to help to support. So a mild infection of a diabetic foot wound, traditionally, 10 days of antibiotics would normally suffice there. When it's more severe, we might need to extend that antibiotic cover. And I guess one of the things that we are very careful to look for in the clinic is whether that wound probes to bone or to deep structures such as tendon, sheaths, or joints. Where that occurs, we know that there's good evidence that we should extend the antibiotic cover to make sure that we try to get on top of that infection fully. And so while we're probing to bone, we tend to extend that cover. And normally that would be about a 6-week duration, though we do sometimes extend it up to 12 weeks, where it's a dirtier wound. If you've had metal, we have a lot of patients who step on nails and that type of thing, or where the infection's not resolving or the wound's not improving. Where we do have, though, extended courses of oral antibiotics, and we know that we've got that infection in that deeper structure, where we're not winning, the wound's not improving. A bit like that case, sometimes the only way to get proper control of that infection is through surgical resection or amputation. Where someone has systemic features of infection, so when someone has fevers or sweats, we would normally suggest or a very elevated CRP. That's normally an indication to come to the emergency department and look at IV antibiotic therapy, even just short term, to get on top of that infection. And as we said, that would be at the Footscray Emergency Department, preferably, because that's where our service is based, and that's where the patient can be comprehensively linked in with all of the team before they head home. When we've had amputations, so Chris touched on this, when an amputation has occurred, often we will take, sorry, not me, but the surgical team, the vascular team will take samples of the residual bone to look for signs of infection. Now, where we're confident that there is no residual infection, the surgical wound looks clean, and those bone chips are negative, then a 5 to 10 day course of antibiotics is sufficient. However, where those bone chips do culture bacteria, that would indicate that there is infection in that residual bone. We've got ongoing osteomyelitis, and that's where a longer duration of antibiotics, or 6-week course, would be indicated. It is, I guess, sometimes time consuming getting approvals for extended duration courses of antibiotics, but in our experience, it dramatically increases the patient's chance of completing that course if they don't have to come back and get a new script, every 10 days. So, certainly getting an authority for that, longer course when it's indicated is a very helpful thing for the patients. And so with that, I'll hand over to Charlotte Cook, who's one of our most senior podiatrists within our service, to talk about some of the practical tips and wound care that we can help our patients with. Thank you very much, Charlotte.
Thanks, Fiona. I think Fiona's already touched upon this, but we are very excited that we managed to achieve an Excellence Award, and we're recognised nationally as an accredited service, one of only 18 in the country. The Centre of Excellence Award, I guess, demonstrates that we actively bridge the gap between the acute, subacute, community sort of outpatient setting very well. So that transition of care is sort of well orchestrated to ensure the patient gets a really good transition from that acute space, as alluded to in Chris and Fiona's talks previously with the case studies, to a point where we can reach hopefully a point of remission, and those patients hopefully are not returning back to our care too quickly. So they're empowered and are able to sort of get on with their lives in the community. Next slide, please. So management from a diabetes foot service perspective, what do we do? I guess you're already partly aware of this with some of the slides that have already gone. But again, I'll reiterate with previous colleagues already commenting on this, that early intervention definitely saves limbs, and it's really impactful on our patients' lives, families, carers, etc. It's a sort of whole approach broadly. It's not just the patient that's involved here. What we provide from an outpatient perspective, again, which is well or fine-tuned, shall we say, with our inpatient unit, is that we offer obviously wound debridement, so excisional debridement of tissue. We also do a minor procedure component within the outpatient setting, where we have the option to do a tissue biopsy and tenotomies, pressure offloading, dressings, obviously with appropriate selection, being mindful of costs that may be incurred to the patient, and obviously appropriate dressing selection with mindfulness with antimicrobial stewardship. Infection management and preventions we've touched upon with the previous slides. Looking at assessment and treatment of vascular disease with the support of our specialist colleagues. Diabetes management, of course, so we're looking at the patient holistically, and not missing obviously the musculoskeletal aspect of these feet changing as a result of the disease process, so involving our orthopedic colleagues too. Secondary referrals can include services such as hyperbaric therapy, which Bernard Allard will touch upon in his talk. Our orthotics team, which are based at Opal at the moment as an external service, but also not forgetting our community-based services that we do rely upon. That's podiatry, our community nurses, and obviously most of the audience that are here tonight, our GP colleagues and practice nurses. Excuse me one moment.
The joys of hospital life.
Sorry about that. Next slide, please. Thank you. I'll just highlight some of the elements that I believe Hui already touched upon in his previous presentation. But patients in our service are usually typically seen between 1 to 4 weeks, depending upon clinical requirements, and obviously that coordinated care we have with our community partners. Early referrals, we've said, is essential to the outpatient service to try and sort of reduce that presentation to the emergency department. What we do obviously say and reiterate, as Fiona's already touched upon, that if anybody is presenting to your care with a diabetes foot-related issue that requires urgent attention, that we do try to direct those patients as much as possible to the emergency department at Footscray. Our unit is there. It will streamline their care quite significantly. Average length of stay for our inpatient often is usually less than 12 days, and an average time spent in our outpatient clinic can range from 3 to 9 months, depending upon presentation, with high re-referral rate, unfortunately, over time. So we hope to empower our patients before they graduate with honours from our team and service, with the hope that their toolkit is full of useful tips and tricks to try and reduce that return rate over time. Our hospital in the home team support early discharge of patients, and that's coordinated by a very specialist team, also inclusive of a podiatrist attending that service, and some of our other specialists within the unit. Dressings can be done by the patients, or say changed with the patient, the family. It can be community-based nurses, GPs, practice nurses, all of the above really, and anybody that's also attending the evening tonight. So it's very important that we pass on the correct information to our patients and anybody involved in that care journey with the dressing changes. Referrals, we do try our very best to coordinate those early in the episode of care, just to help to facilitate discharge, and obviously any identified additional services that may support the patient, for example, exercise physiology, again, might be identified early on in the process. Next slide, please. So I'll just quickly touch upon this slide here. The International Working Group Guidelines for the Diabetes Foot is largely a large body of evidence that we do rely heavily upon to guide our day-to-day running, shall we say, of the clinic, and there's many domains that you can see on here. Chrissy's presentation did touch upon, obviously, the neurovascular elements that we do conduct when we see our patients, and there's handy tips in the prevention and management, domain or chapter of that particular guideline that gives you sort of pictorial reference on how to complete the assessments and what the recommendations are based there. If you can just click through the slide, thanks, Chris. The things we'll just focus on this evening, just with the interest of time, is just to highlight some elements that we have available to you from an offloading perspective, and also that wound healing. What can we do as a audience today to help influence how these wounds can heal? Next slide, please. So the offloading components, often in the diabetes foot world, in the research that's out there, we usually have this slide put in our presentations to highlight, I guess, the best elements for our offloading that are available, and they sort of, I guess, rank them between 1, 2, and 3, a bit almost like gold standard, silver, and bronze. From the point of view of the International Working Group Guidelines, they recommend that we have a non-removable above ankle device to offload a plantar foot ulceration. So the two elements you can see on the sort of podium on level 1, you've got a total contact cast on the left and a instant total contact cast on the right, which is essentially a cam boot or moon boot that has strapping or adhesive tape wrapped around the device to reduce the risk of the patient removing the item. The next sort of element down the line, you've got, again, on the silver category, we have the cam boot option, again, that is a removable item, and then some elements there that sort of have a lower ankle device and a below ankle device there. So what we're looking at from the point of view of offloading is trying to obviously get the highest percentage offloading with the device that we put on. elements that are closer to the point of the knee or above the ankle. Around about 80 to 85% of the body weight is taken off the plantar aspect of the foot. And as we go lower down the leg and below the ankle, obviously that percentage reduces significantly. The element with the third category, or the bronze category, there is some justification to continue to use a medical grade shoe option, but that must have some form of offloading device in there. And just there's a picture there of a semi-compressed felt option that has been added to the plantar aspect of the foot. If over a set period of time, sorry, Chris, nearly finished with this one, after a set period of time, we're talking, so within a 6-week time frame, that there is not a great improvement in the wound trajectory, even though we've optimized offloading, we've looked at the patient holistically, there is the option to consider a surgical revision and alignment of the feet, which is just demonstrated in those pictures there. Next slide, please. So the other element that we touched upon was the wound care component. And this is where hopefully some of our audience members can assist in this space. So this is a scheme that the government has introduced quite recently. It's the Chronic Wound Consumable Scheme. It covers the costs essentially for wound consumable products for people living with diabetes and chronic wounds who are over 65, but those who are identified as First Nations people would be 50 and over. There are a few elements in relation to eligibility for this particular scheme. And what I would actively encourage, there is, again, an opportunity for CPD recognition to actually complete the online modules that are associated with a particular scheme. Essentially, once you've completed that, there are modules contained within there that talk about how to assess a wound, similarly to the what Joe had mentioned earlier in relation to the health links section of the education. Those components can be accessed at any time, and you essentially end up with a CPD component at the end as acknowledgement for completing those modules. You then register within PRODA that you are a registered scheme member and that you're eligible for your patients to actually approach you to coordinate the chronic wound scheme elements. And then you're able to order certain wound care products that can either be delivered to the patient or to, say, the hospital or the community-based setting. So I would encourage those of us that are attending this evening in the audience to maybe look certainly on the website a little further in relation to that particular scheme, because it will probably be very beneficial to most patients that you do see in your practice. Next slide, please. Just to finish up sort of with my presentation, Fiona had already touched upon, I guess, a flow sort of diagram to demonstrate some of the elements that you would look out for patients with active disease. This integrated pathway sort of helps hopefully to try and maintain patients within a remission state. So you have sort of elements here from the Foot Forward team and the NDSS, where we look at the risk of foot disease development, and they rank it from high, moderate, low to very low, and then give you, I guess, guidance or action points to sort of help those patients hopefully maintain remission.
Thanks so much, Charlotte. Yeah, it's certainly a massive part of what our service does, and you know, it really is the backbone of everything, that offloading and dressing care. So thank you. Now I invite Bernard Allard, who's our head of vascular surgery, to talk about some of the more novel surgical approaches to diabetes foot disease. I apologise, we are running over time, but we'll try to still make time for some questions at the end if possible. Thanks, Bernard.
Thanks very much, Fiona, and thanks everybody for attending. It's really good to have such engagement from general practice and community podiatry. Hopefully we're providing a good service for everybody, so I'm certainly keen for some feedback on that, and hopefully our referral pathways are adequate and simple for people to follow. So there's just a couple of points I wanted to make this evening very briefly. I won't go too much into revascularization, But as everybody's probably well aware that ischemia is one of the main contributing factors to diabetic foot ulcers. And as David Armstrong would say, it's toe and flow. So toe, we look after things from the podiatry point of view, look after the offloading and pressure cares. And then there's the flow, there's the vascular side of things. The etiology of diabetic foot ulcers is really coming from three different areas. There's the purely neuropathic patients, there's the purely ischemic ones, and then there's the ones in between, which have a component of both. And so looking at the ischemic, we really need to address the flow of that, but not forgetting all of the offloading and all of the other things that we need to do. Next slide. So when you're referring patients to our unit, we want to make it very simple. The standard of referrals are excellent. So thanks everybody for what you do in referring the patients in here. But there's a couple of things you probably want to know just to make things a bit easier and know that you're providing us with the right information. Next slide. One thing that is actually really useful is the history. So claudication, the tightening up in the calf muscle when a patient walks a certain distance, certainly very useful to know, and the distance of that. But rest pain, as you can see from this picture with the elderly lady laying in the bed with the legs hanging down between the cot sides and the diabetic foot. If the patient does have rest pain, we know that this is a more urgent and pressing situation, that their limb is really at risk. So very important thing to know. From the investigation side of things, good to know what previous duplex imaging that they've had, if there has been documentation of any significant arterial occlusive disease, any angiograms or more sophisticated interventions, or CT angiograms or the like. Interventions as well, be that operative with femoropopliteal bypasses, endovascular revascularizations, or even amputations of toes. It's quite important to get a bit of a heads up on this on the referral. Next slide. Examination, you're all familiar with the ischemic foot, colour, temperature, capillary return, pulses, very important things. But there's a few other more subtle things that might not be noticed, such as traffic changes in the skin, thin, shiny skin, nail changes, hair loss, etc. Surgical scars are a great one too to know about, so that we know if they've actually had a previous bypass, endarterectomy, or other vascular intervention, or if the cardiac surgeons have already stolen their veins, so we don't have a bypass conduit. When you elevate the leg can become pale, and it is a good indication that there is significant vascular disease. Next slide. From an investigation point of view, just keep things simple. So we asked maybe just a duplex scan. It's cheap, available, low cost. There are some issues with duplex scanning. It is very operator dependent, so we do get a variability in those scans. Vascular calcification, a bit like in the image to the right, you can see the bone there where you get a white layer at the surface of the bone and then an acoustic shadow behind that. If there's calcification in the vessel, it'll do the same thing, and we won't be able to see inside it. So ultrasound gets reflected off as a white line and doesn't get through into the area that we want to interrogate. And ultrasound is a fairly poor predictor of healing. So in these slides, I'll go back. I've just given some examples of a fairly normal pulse waveform in the common femoral artery where the velocity is around 100, and a triphasic pulse waveform. The next section shows the peak velocities within the artery at 412 centimeters a second. So when there's a narrowing in the artery, the blood has to flow faster through that narrowing to maintain the same overall flow rate. So you'll see an acceleration of velocities indicating a critical stenosis. And then often below, downstream from that, you will see the monophasic, very sluggish flow and low flow of only 24 centimeters a second through the vessel after a critical stenosis. So this is where ultrasound can be very useful for us, just to give us a planning and mapping of what we can expect from the vascular supply. Next slide. X-rays are very useful. We like them in at least two different planes because sometimes lesions can hide in one plane and be more apparent in the other. So simple X-rays, very useful, showing osteomyelitis, bony deformity, and fractures, for example, pathological fractures. In this picture on the right side there, you can see that there's osteomyelitis of the head of the fifth metatarsal, and the phalanx is almost hanging in the breeze there. You can see some periosteal reaction around the distal shaft of the phalanx and an island of bone just floating in the breeze there. So it gives you quite clear indications of osteomyelitis. The one thing that is a trap is that the changes on X-ray can be significantly delayed from the actual clinical scenario. So it can be up to 5 or 6 weeks delayed. So the initial X-ray may look fine. However, there is actually osteomyelitis and infection going on in the bone. So that's a bit of a trap. Degeneration, such as osteoarthritis and osteomyelitis, can sometimes be very difficult to tell apart, particularly with gouty arthritis. Next page. CT scanning can be useful, just plain CT, looking at the bones. So if you're not quite sure whether or not there's underlying osteomyelitis, this can be quite useful. The top picture shows that penetration of the ulcer underneath the foot into an area of bone that's lost its cortical margin, has that irregular surface, and is osteopenic, suggestive of osteomyelitis there, which is again confirmed on another slice down a bit lower where you can see the erosion of that already disorganized first metatarsal, which has undergone regeneration over time, and then there's secondary osteomyelitis again in the area that's previously healed. So it can be quite useful. Next slide. CT angiography is amazing now. It's fast. It can subtract away the calcification. You get these wonderful 3D images, multiplanar reconstruction, etc. However, it is fairly expensive. It gives the patient a big dose of contrast. So we really don't want that in somebody with any renal impairment before they come in, when we might need to do some significant angiography work. So it's best to try and avoid contrast imaging. It does give fairly poor indication of the tibial vessels, as you can see on these scans. And so probably not advised. And there's probably limited access to CT angiography as well from a general practice point of view. Next slide. So looking at how we manage ulceration from a surgical perspective and point of view. The first thing is ischemia. So we manage that with bypass, endovascular treatment, or other forms of revascularization. Then once we've achieved good flow, we need to control the infection. So good antimicrobial stewardship to make sure we've got the right antibiotic for the type of infection that's existing and that we're covering a reasonable spectrum, not an overly broad spectrum. We need to address the neuropathy with protective footwear to make sure they're not causing any further damage in the foot. We address deformity with offloading to try and protect those areas that are having pressure on them that wouldn't normally have that pressure. And lastly, surgery to operate on those areas, which might mean debridement, amputation, limited amputation, or just cleaning up the infected tissue. So what happens if we get to this point and we're still failing to heal, or we've got a wound that we just don't know, is it going to heal? Next slide. So we sometimes end up with a picture like this, which looks horrendous. However, the first question we need to ask, is this even salvageable? Is this going to be a useful foot for somebody to be able to walk on, even if we do get it healed? And if it's not, there has to be serious consideration for a below-knee amputation. However, if it is potentially a functional foot, if we can heal it, how are we going to close this? We've got bone there, we've got tendon, it's open to infection. Our traditional methods of putting skin graft on this isn't going to take on bone and tendon, and there's this gaping hole and deformity. So what can we do? So our new technology, next slide, is a company in Melbourne called Bionova has developed this biodegradable temporizing matrix, which is a synthetic artificial dermis, essentially, which is a polyurethane matrix, which has certain pores and cavities within it that allow granulation into it and the development of an artificial dermis. Next slide. This is what it looks like close up. So the matrix is open cell, a couple of millimeters in thickness, and this scaffolding allows for ingrowth of the cells within the wound. And it's quite interesting the way that it just has to be a little bit of blood flow into here, which encourages these cells to migrate through into these tissues, and you get an amazing regeneration through it. The sealing membrane on the top is not biodegradable. It's there to limit the fluid loss, moisture loss from the wound, and also to some degree act as a barrier to bacteria. Next slide. Next slide, next section again. So this shows you how we apply the BTM onto the tissues. It's actually good to have some bleeding because it actually infiltrates up through the BTM and provides that basic milieu of cells that are required to stimulate generation. Into this, it's basically a compact granulation tissue which has some structure in it, which very closely resembles dermis. And then once the outer layer, the temporizing, the sealing membrane is removed, you get this lovely surface that will take a skin graft very well. Use slide. So this is a patient that's had a guillotine transmetatarsular amputation for a serious forefoot infection. And this has been covered with the BTM on the right-hand side, which is sewn into place, and some compression is applied. Then a vacuum-assisted closure device is placed on this for a number of days. Next slide. So we use the vac dressing, we change it at regular intervals, and then usually after a couple of weeks, we can leave that off and just dress it with simple dressings. And from 28 days to a couple of months, the sealing membrane will gradually delaminate and we can take that off. And then the resulting granulation, we can generally either skin graft or it may actually heal by a secondary intention. Next slide. So the benefit is that we can get coverage of that bone and tendon that we otherwise wouldn't have been able to do with a skin graft or a free flap or something like that, because these patients usually have significant peripheral vascular disease and that flap just won't survive. It provides that artificial dermis, which is protective as well as ready for skin grafting, and can also cover in the defects within the foot. So we can actually build up layers of this BTM inside, underneath the main outside layer, so that we can fill in these defects and get the granulation all the way through. And it gives good moisture control to the wound so they don't dry out and die back, and is somewhat resistant to infection. And the patient can move about while they've got this applied. Move on with the slide. We've been concerned about infection with any sort of prosthesis or device over the top of these wounds. However, the BTM seems to be fairly resistant to this, which is very useful. We can, if they do develop an accumulation like we can see here, you just put some fenestrations into it and you can drain it out. And the wounds can actually be covered quite well with this in different conformations, and it adapts quite well around the contours of the body. Next slide. So these are some studies. Mainly the investigation has been in relation to burns patients, and Heather Cleveland at the Alfred has led a good group with looking at this, as well as overseas. And despite infections, there's a really good take of these type of grafts with very limited adverse effects from it. So it's been very useful for us to actually have this material. Next slide. So the other element to this, we can now do something about covering the wound and getting it healed. But what if we do get to the end of this road and we're still not healing? Next slide. So hyperbaric oxygen is our last line of defense, basically. There is a high degree of evidence for certain conditions such as divers' bends or decompression illness, carbon monoxide poisoning, but there is also moderate evidence for diabetes, foot wounds, radiation injury, necrotizing fasciitis, as well as in some cases in burns. There are some contraindications, so not all your patients can go into the chamber if they've got an implantable defibrillator or other history of congestive cardiac failure, then they can run into trouble in the chamber. Middle ear injuries, so they can't tolerate the change in pressure. It does stimulate cataract formation, which is mostly reversible when they come out. And it's a little bit of a confined space, so claustrophobia is an issue. At the moment, patients have to travel daily to the chamber 5 days a week. It's a bit like a full-time job. And the only chamber in Victoria at the moment is at the Alfred Hospital. It's an old chamber, and a third of the time it's actually out of action. And there are considerable concerns regarding fire within these chambers. However, there are strategies to mitigate that risk. New slide. Yeah. Hyperbaric oxygen for diabetic foot ulceration does have good evidence. However, it's hard to prove a lot of things, because going to the chamber every day, they get really good wound care and management. So that is certainly a contributing factor to improving our healing rates. However, overall, we can prove that there's fewer major amputations in the hyperbaric groups. However, there's no real difference in the minor amputations and healing. And that's basically all we can really prove. We do know that with better patient selection, we can optimize our healing rates in treatment of the diabetic foot infection. For those who we have done all we can for their revascularization, if they do have low tissue oxygenation and we've surgically optimized the wound, then a referral to the hyperbaric unit may be the best thing for these patients. And there is some good news, is that we should be having a hyperbaric unit open sometime in late January of next year at our Sunshine campus. So this is going to be very beneficial for our patients. Rather than travelling through the traffic to the Alfred, they'll be able to have their treatment a bit closer to home, which will be terrific news, and we'll hopefully be able to update in the early new year on that.
Thanks so much, Bernard. And yeah, sorry, apologies to anyone who might have been eating dinner. During this presentation, we probably should have put up a little bit of a warning about some of the images we might be showing. But certainly, it's an exciting time in terms of, you know, those novel surgical approaches. And you know, as Bernard said, I guess, you know, one of the things we really want to make sure is that it's easy for people to refer. You know, we want to make sure that patients have access. You know, to our service, in a timely manner. So, can we keep going, Chris? So I guess, you know, one of the things we do talk about is preventative disease. I'm conscious of the time, so we'll try to get through this, you know, I guess quite quickly. But yeah, please remember to remind patients living with diabetes about the importance of foot checks. The sooner we find a wound, the easier it is to manage. We want to try and prevent the first ulcer. So we know that things like smoking cessation, you know, management and preventative care around peripheral vascular disease, lipid optimization, that type of thing is really important. Good footwear, good pedal hygiene, you know, treating fungal infections early before they become advanced. This is all, you know, really important in terms of helping to prevent that ulcer. Once we do have an ulcer, you know, looking at recognizing, you know, when it's infected, starting empirical antibiotics with that broad spectrum cover early, then, you know, moving on to directed therapy as guided by the wound swabs, is important. And then obviously referral to an appropriate podiatry, yeah, and or high risk foot service, such as our service is really important. Sorry, Chris. So how do you refer to us? So we've had a little bit of a difficult issue with our Western Health website. It's undergoing a number of upgrades, as many of you will be aware. There's a lot of changes at Western Health at the moment in terms of you know, expansion in Melton and you know, incorporating Bacchus Marsh services. So, you know, it is a little bit hard to find directions to our service at the moment. Certainly, we want to see these patients, you know, where there's been a wound for a month or so and nothing's improving despite medical management. We want to know if you think that there's a Charcot, you know, please, you know, get an X-ray, give us a call. Where there's foot osteomyelitis with ulceration, chronic ischemia, or with neuropathic symptoms, please, you know, consider referral to our service. As we said before, where you think that there's an acute limb ischemia, where we've got, you know, active tissue loss and absent pulses and signs of critical ischemia, or where there's sepsis or systemic features of infection, please, you know, ask the patient to attend the emergency department. And as I said, Footscray, is where our service is based. So it is a much more streamlined and satisfactory experience for patients if they come to Footscray first. They don't have to wait for transfers to Footscray. Sorry, next slide, please, Chris. So this is our referral guidelines. We can send this to anyone who who would like a copy, at the end we will make the recording available, and certainly this is our referral guideline. You can access it on the Western Health webpage, but it seems to have gone under an allied health thing. Obviously, we are a co-located service. We have a lot of medical support, but also significant support from our podiatry team. So it is a co-service, but yeah, as I said, this referral guideline is a bit hidden at the moment, but please, I guess one of the things we would tell you is that we do have a direct phone number to our service, so it's 83456922. If you've sent a referral, you've not heard back, or you're not sure where to send it, please give us a call so that we can help you. Sometimes referrals do end up going off to diabetes clinic or to podiatry clinic, and we do redirect them as quickly as we can, but it can delay the process in terms of making an appointment for your patient. And as we said, time is tissue. So this is our phone number and our email. Please email us your referrals. We do have a fax number as well, which is on the other thing, but our fax machine, can play up at times. So as I said, please don't hesitate to pick up the phone. And I would also encourage any GPs that we're partnering with to manage patients. If you're not sure or you'd like to talk to us, please give us a call. We may not, there's not necessarily always an endocrinologist or an infectious disease physician or a vascular surgeon available, but we do have an incredibly experienced team of podiatrists who are in the clinic, and also we are happy to call you back because it is a partnership and we are managing these patients together. So please don't be afraid. We're all friendly and nice, and we just want to see the best outcomes for our patients. So with that, are there any questions? I apologise for the time delay. If you'd like to put questions in the Q&A, we can certainly address them now. I think the only question has been, will the recording and the slides be available? And the answer is yes, we will absolutely make the recording available. And as I said, we are happy, if you do have questions or there's ways that we can support you and our partnership managing these patients in the community, please get in touch. I don't think there's any questions.
No, I can't see any.
Three?
No, I think
no, everyone's. Excellent. Oh, we've got one question. Can we refer from Ballarat? So Ballarat actually have their own. They do have a high risk foot service in Ballarat. But if you've got patients who you might be seeing in Ballarat who are living within the Western Health catchment area, then of course we'd be delighted to see them. So this is an interesting question. Do you have a wellbeing coordinator or is there a case coordinator to help with the social determinants of health? So that's a really interesting question and a really important part of managing diabetes related foot disease. Certainly, we have a strong interdisciplinary service and we do provide a lot of support for patients in terms of when they are in our clinic. It's really a very comprehensive experience where they'll see a podiatrist, at the same time they'll see a diabetes educator, and then often a medical practitioner, so endocrinologist, infectious diseases doctor, or vascular surgeon, or orthopedic surgeon, and patients will see various health professionals on their subsequent visits. We do try to address some of those socio, and social factors, and certainly, we do try to make referrals where we can, to Bolton Clark or other services that can help to assist patients at home, because it is a really difficult time, when you can't get your foot wet and you can't go to work and that type of thing. We do have some limited access to dietetic services and social work support. But also, I guess, we're trying to incorporate with DFS psychology, trying to help patients access the psychological support where those kind of barriers might be preventing them from engaging with their healthcare and from, engaging with preventative health overall. In terms of financial constraints, I mean, that's a huge problem for our patients, and particularly in the West. And I guess we do try to support them where we can in terms of accessing financial support, but we don't have a dedicated social worker per se that can help, link these things in. So thanks, Casey, for her comment. Casey's our DFS manager, and really does a wonderful amount of work for our service, and without her, we wouldn't be able to offer any of the kind of support that we do. There's a question about, can we refer from an aged care facility? So it's a little bit tricky in terms of patients from aged care, in that we can't facilitate ambulance type transfer. So patients have to be able to get to us, under their own steam, so a family member or someone needs to be able to bring them in. However, we do see patients from aged care. Usually this would be something, though, that we would hope to partner with the aged care service because of the logistics and certainly in terms of management of blood glucose levels and the like within aged care. That's often going to be predominantly GP driven. So we do see those patients, but we often will hope that the aged care team and the support that is there will also help to take a more active role with the support of our service. The next question, is there education relating to performing a foot check in a GP setting available at all? I think that's probably a really important thing and probably actually a really good thing for us to try to develop. We don't have a particular unless Charlotte's going to correct me.
Yeah, I can step in quite quickly here. The consumer scheme has actually got a really comprehensive modular-based, I guess, course, shall we call it, whereas say you do earn CPD. Excuse me, as part of that, you do get a comprehensive guide on how to assess a foot. But as I say, I would draw your attention to the International Working Group guidelines. And obviously, I think Joe did comment earlier in the presentation to the other elements where you can sort of draw upon with the health links components too.
I think, if there's any more desire for a kind of streamlined thing that maybe we could look at putting something like that out too.
Next, I think the GPs look at the Health Pathways Melbourne, and there's also been some GP journal articles on how to perform a diabetic foot check. So if you look at those as well.
Excellent. Thank you. Any tips on how to communicate with a patient who's living with type 1 diabetes, who's had an amputation, who is also a heavy smoker? Look, we try. I don't know that I know the answer to this one. Certainly, I guess we try to deliver a lot of education on that and the effect of smoking. I guess one thing I would say is that often this is an opportune time for patients to really take these messages on board. Other patients find that the stress and everything actually exacerbates their desire to smoke. But really trying to help with that education and support around smoking cessation is an ongoing thing. And if anyone has any really great strategies that work all the time, I think we'd all be happy to share them. But it is a really important time to talk to patients about it. And as I said, with respect to so many aspects of their care, facing an amputation or undergoing an amputation. It's a time when patients are really motivated to make some changes about their health, and it's a really important time to try and do some of that preventative health work. So we've just got a comment. I'm a community nurse at Western in Melton. We visit patients who use the DFS for wound care, and they are fantastic. Thanks so much, Karina. And you know, I would have to say that I know I'm biased, but I think our team really does a wonderful job, and we really have a great group of people who are all really passionate about foot care and helping to improve the lives of people living with diabetes, foot-related disease, as evidenced by how many of us are here tonight. We really just want to see the best for our patients. So thank you. Were there any other questions that we can? I think that's all. So look, I'd just like to say thank you to everyone who's joined us in particular. Thank you to Chris, who has coordinated this evening, Hui for all of his hard work, Bernard, who is an exceptional surgeon, and has put a lot of work into tonight's presentation, and to Charlotte, your expertise and enthusiasm is infectious, and really, I think it's fair to say no one works harder than Charlotte in our service. So with that, I'd like to say thank you to everyone who's joined us tonight. We appreciate it's late, and sorry we've gone over, but we really hope that this has helped some of you, and we really encourage you all to work with us and let us know what you need as well. So thank you very much.
Great. Thanks, Fiona. Thanks to everybody for attending. Please ensure you provide feedback when you get the feedback form from the PHN, from Eliza, that will come out, because we really need to hear from you what you would found helpful, what else you would like to know about, because we're planning our education program for next year. So, and again, thank you to all our presenters. It's been a fantastic session. And thanks to Eliza behind the scenes tonight. We couldn't do it without the PHN supporting us with all the tech, because that's all beyond me.